everything. So he was already on analgesics, he was on physiotherapy. The first thing we did was the least invasive thing, this is a myofascial injection. The myofascial injection is just basically needling the tightened muscle. So you break the tightened bands. So just a plain needle, even acupuncture needle, which is the smallest needle, can just take a needle and start puncturing the muscle, and you get relaxation of muscle. So that is why acupuncture is important. I mean, acupuncture can be make use not for energy lines, but if you just put the acupuncture needle, do dry needling on a tightened muscle, the trigger point, you get the muscle fully relaxed. No medication will do. So we started doing myofascial trigger point injection. And a couple of weeks later, he came back. His pain was very much less, but now he was complaining of more sacroiliac sort of pain. So then we went to the sacroiliac. Actually, sacroiliac injection again cannot be done blindly. It's a very deep-seated joint. Only the lower third is synovial. Upper part is not synovial. So go to the lower end of it and then treat it. So did an image-guided sacroiliac. That took most of his pain actually, but after about 2 months, he came back with mainly radicular component of the pain. So he only had the radicular pain, the back pain was completely gone. So actually, what we did actually was we did a selective nerve root block, this L5 nerve root block, we did on both sides to see because he had two bulging discs, one on L4 file and then 5S1. So we blocked the L4 nerve root first, so if it is causing pain. So he gave contrast and then the local anesthetic. And there was some pain reduction, but it was not complete. He did a L5 root block also, selective nerve root block, and that took his pain. So we injected him with steroids. So for the next 3 months or so, he was completely pain. That is the duration of action of basically steroids. And mind you, this is the most effective treatment. Interlamina, you go posteriorly and do epidural and inject, it won't go to the affected nerve roots. Because nerve roots are placed more anterior. It doesn't go to the anterior epidural space. Only half of it will go to one side. Again of that, another 1/3 will go to the affected nerve root. So only 1/6 of the injected will go into affected area if you do an interlaminar posterior approach. So if you do transforaminal, go to the neural foraminal, do it. 100% you will get contact. The second thing is, these are all liquids. When you inject it, when there's a resistance, it won't go to the affected side. So when there's a root block basically, by this, the injected won't go there. It will go to all other nerve roots, but not to the affected one. So you won't get pain. So interlamina is not evidence-based. It's a harm actually. You can get side effects of it, not any effects. So whereas if you do a image-guided root block, so, and the epidural, it will cause more pain and it will be sometimes therapeutic. So we did that. After 3-4 months, he came back, and then he was not basically willing for a surgery. And his disc was disbulging. It was not sequestrated out. Only other option left was actually to take the disc out. So then actually we did a decompressor discectomy on these patients. Simple 30-minute procedure. Put a cannula into this L4-5 disc actually, and through that first small drill that sucked out the whole disc. Just take 2-3 minutes. You keep the drill 3 minutes, and the pressure inside disc will go down. So the bulging will be reversed. So this is what I am doing there. So it took 30 minutes. Done on the local anesthesia. Patient walked out of the bed. Next day he went home. Completely pain-free. So prevented him going to a big surgery of 3 or more hours, and he will be pain-free for another 1 month or so after that. His extensive rehabilitation. Whereas with this simple procedure actually, not a very big thing, and the CR without much complications. Went back home next week. So it's a complicated patient, but all spinal patients are like this. They are complicated cases, not just simple disc prolapse, causing pain. There will be facet pain, disc pain, radicular pain, on top of that myofascial pain. So you have to address them individually, otherwise they will be painful throughout, and eventually get complex renal pains also. So with that, I think that's one of the cases there. PSS, I'm not just sacral leg joint dysfunction. I'm not going to go through in a big way. This is a lady actually who came to Bangkok, is retired prematurely because of pain issues. She had gone around the country and ultimately had no pain relief, decided to retire. Came back to me as Fadul actually. He had all the features of sacral leg dysfunction. So what I did was I actually, the Zevia virus, injected sacral leg intraarticular and you see there's something new coming up called prolotherapy now. Prolotherapy is proliferative therapy. Now for all degenerative diseases, the treatment is region treatment. So certain chemicals have this regenerative potential. For example, lignocaine itself has some